programme of education events in Northumberland. We've got Dr. Kathy Petersen, a partner at Forum Family Health and Northumberland's clinical lead for LD, mental health, autism and children. She's going to speak about how practices can identify the groups of patients that are most likely to not attend clinical appointments and how we can record that information on their record, but also how we can look to make reasonable adjustments when setting those appointments and how we can follow up those vulnerable patients who do not attend. Kathy's already done this with the GP Collaborative a while ago. We all agreed it would be a really important presentation for Kathy to share, and it's based on an awful lot of Kathy's experience over the last 5 years or so. So with no more rambling from me, I'd just like to hand you over to Kathy.
Thanks, Michael. Hi, everyone. For those of you who don't know me, it's lovely to see you, and thank you for staying for this. I know that's not a given. Can I just check, am I sharing that? Is that sharing? No?
Yes.
It is. Oh, brilliant. Thank you. Fab.
It's sharing, but you're a little bit faint voice-wise, Kathy, which is not something I would normally say.
That's rude, but maybe true. Is that better?
Perfect, thank you.
Right, great. Okay. So thanks, everyone. So what is Adult Not Brought? Why have I done this work? So I'm a clinical lead and have been for many years about learning disability. And basically what happened was I started to see in my surgery years ago that patients weren't coming, and I didn't really know why, and they didn't seem to have DNA written all over them. They seemed to be not brought. And I realised that we were very cited on this for children, but not so much for adults. And although NHS England recognise it, they don't give us any ideas about how to do this, how to manage it, how to recognise not brought, how to document it. And until I asked for it, there wasn't a code about adults not being brought to appointments. They only had the child not brought to appointment. So about 4 years ago, I asked for the code, and I thought, right, well, that'll be it. I'll just get a code and what's your own code. Turns out that the next 4 years were spent trying to work out what to do with that code, because really what we don't want is just to have this code and not do anything about it. So as I say, 4 years I won't get back. So historically, DNA was the only code we had to record someone not turning up who is a vulnerable adult. And it's really not accurate or appropriate if someone doesn't have capacity, mental capacity, or doesn't have capability to attend on their own. And we can now code these as adult not brought to an appointment. And really, the whole point of doing that really is so that we can recognise it and make reasonable adjustments. And I'll talk more about them in a minute. I think for me, we talk a lot about child not brought in our supporting families meetings. We talk about them as a very, very acutely, certainly in my practice. And I think it's really important that we think about these vulnerable adults in a similar way. Unfortunately, because we haven't been coding not brought rather than did not attend, we don't know how many people this applies to, but I suspect that from my clinical experience and particularly another practice in Critters Park, we think there's quite a few. And what we don't know is how many of our missed appointments are not brought. We don't know how many of our discharges from clinic, our non-diagnostic completions are actually not brought. And it's partly because we're not counting it, but also because capability and capacity assessment is hard. It's multi-agency and it just takes time, and you've got to really think about it. I've had a lot of partners in this work, and we don't need to talk about it specifically, but I realised because we work on Northumberland that you can't just think about Northumbria, you have to think about Newcastle, and then that widened it out, and then that's why it's become such a massive thing. But I have specifically also engaged with adult social care in Northumberland. I haven't got regional buy-in to that, but I think it's really important that our social care people are with us on this. There's a number of things that can help us. We know that there's a reasonable adjustment digital flag coming where we can document reasonable adjustments in any setting, and it will show across all settings. So that will really help us document what patients need to attend. Also, Oliver McGowan mandatory training, which you also should be all doing, is one of those ways in which we can raise awareness and experience of learning disability and autism. And I mean, I've been doing this a long time, and I learned quite a few things on that training. There is actually legally an accessible information standard. North East Northumbria average reading age is 8, and most of the outputs of our secondary care and primary care work is not at a reading age that most people would find accessible. We know from a number of domestic homicide reviews and significant events that adult not brought does actually contribute towards morbidity and potentially more mortality. I think there's lots of reasons why people aren't brought, and we know that poverty, deprivation is one of them. Gareth Forbes talked about the vulnerable patients. You know, we can think about this differently and we can make it better. Core 20+5, you might not have heard that. That's a national approach to reducing healthcare inequalities, and it's, I think, an important contributor to that. It's really part of personalised care, I guess, and we know from a Health Watch Newcastle report that reasonable adjustments accessibleness is actually really helping, and patients like it. So obviously I've come from the learning disability and mental health arena, and I also look after our autistic population, but I think this also applies to our frail, our demented patients, our ones with sight loss and hearing loss, our patients experiencing domestic abuse, and our patients with ethnicity where they don't have English, or where they don't have English as a first language. And obviously we have patients perhaps with delirium or an emerging dementia where they might have fluctuating or we're at risk of capacity. The other big group that we've been working with are those who are over 16 but under 18, who they have the right in law to make their own decisions if they have capacity, but actually the child not brought work doesn't really fit them. So I have been asked to do some regional work on that. Should be quicker to say no. So what do I really want from this? I guess for me, there's something about recognizing the groups of people who might be at risk from not being brought, so our demented patients. And what can we do to make sure that is highlighted in our notes? So you might want to code a vulnerable adult. You might want to make sure that dementia is very, very clear in your notes. And you might want to put a pop-up about if this patient doesn't attend, ring carer, or, you know, so really this is about personalized care. And the big thing for me is to make reasonable adjustments from the outset. So anyone with any of those vulnerabilities, you want to be making that appointment with the patient, with the main carer, to make sure that that person can actually attend. So, for example, your carer that can only come on a Friday, well, we're going to have to work around them. If they can only come on a Friday, that's the time when we want to see that patient, unless it's an acute situation. So if you make the reasonable adjustments at the outset, so with the social prescribing link worker, with the receptionist, with the reception at the hospital, then we're going to get a much more likely time when we get the best outcome and the best appointment for that person. So we reduce all sorts of stresses. The other thing is we assertively follow up child not brought. Why don't we do it with adults who are not brought? We should be doing that. We should be asking the same questions as we do with a child not brought. So I've written a whole strategy, which is at the end, all of the links and everything are at the end of the talk. But there's some top tips. I think it's really key, and I'm sure all of your practices, you know your patients with a learning disability, and actually you probably know all your patients with vulnerability. You can code adult not brought to a point when that happens, but actually I would really like you to code. Actually, we've tried to look at this, and we've tried to make that appointment easier. This is how we've done it, so you can recognise it for next time. And with the reasonable adjustment national flag, we will have a way of doing that going forward. What the national flag doesn't do is tell you what to do with that information, and I think that's something that the reasonable adjustments campaign and this work can help you with. There's a range of tools that we've developed, and I've put them in the strategy. All staff need to be aware of these patients. All staff, so particularly reception staff, particularly your triage people, particularly your social prescribers, so that you can get this communication, get it right first time. For me, carers' needs are really key here. Carers are how we manage with these patients 99% of the time. And I'm talking here about social care providers and professional carers, as well as family carers. Now, all of these people do not bring their people to appointments on purpose. We've done some work in our practice, and actually we have a supported living and a care home on our patch. And what we found was the letters that we were sending, even if they were easy read, they might be going to the patient, but the patient wasn't sharing that with their carer or their manager. So the actual appointment that we sent or arranged with them wasn't necessarily getting into the diary. So when they weren't brought, it was literally because the appointment wasn't in the diary. And what we've done is we've got to all of our patients talked about consent to data, and actually put in place so that we actually get the managers to have the appointment at source, so they can see when the appointment is, and then they can work their staffing around it. You know, finding on the day that someone's got an appointment in 5 minutes, you're not going to be able to get the right staff. You're not going to be able to get the right cover for your care home or your supported living. So carers are absolutely key in this. There's all sorts of things like carer passports where we can actually meet the needs of our carers better. We can think about, you know, if they need an appointment that day as well, why don't we do it together rather than getting them to the surgery twice? We know that there's a number of professionals that work really to support our learning disability population. We've got care coordinators, we've got liaison nurses. Some of the other vulnerable groups don't have so much support, but actually we need to be flagging that to the people that are looking after our patients, and actually, you know, what support do they need? How are we going to do this? One of my learning disability patients, his mother was starting to dement, and we had a real problem getting him to appointments, and actually we had to involve social care. And actually it caused, you know, significant improvements in that man's health, getting into the appointments that he needed. I think it's really important that all staff in the team are involved, and there is some workforce training that I think would be really useful for your staff. As part of this work, we've also developed a reasonable adjustment campaign. We've all probably heard the phrase, but what does it actually mean? This has got a QR code, so patients, carers, family carers, professional carers can actually look at what that actually means. And we're going to do a number of other photos, because obviously lots of patients don't look like they have any sort of disability or vulnerability. So actually things like people like veterans, they might not respond to a poster that considers disability. So I'm sure you've all seen Easy Read before. I'm sure you've all got Easy Read options for your patients with a learning disability. There's MenCap have done 10 top tips. This is what it looks like in Easy Read. I suppose, what am I aiming at? What do I think this is going to achieve? If you're brought to an appointment, hopefully you're going to get better long-term condition care. You're going to get earlier diagnosis of illness. You're going to get completed investigations and diagnostic processes. You're going to get more of your vaccinations. You're going to get more of your annual health checks. I suppose going forward, we'd like to see a reduction in the number of non-attenders to appointments, lost to follow-up, a reduction in the number of discharges from outpatients, and really key, reduction in emergency admissions. We know patients attend in extremis with late presentation of illness because they haven't been able to complete their diagnostic process. And I really want to think about reducing the stress and trauma of attendances which are of low value, and the carer stress involved in that. So I think we've got a lot of potential here. Obviously I can't give you numbers, but my sense is, and what I've heard from secondary care particularly, is that I've been asking them to come, they haven't come. I've asked them again, they haven't come. We've discharged them. So the amount of time that they've spent working out that this person hasn't come and re-inviting them, actually they could have rung the carer at the beginning, organised a suitable appointment, and that patient might have come, or might more likely have come. And I think we have to think about where do we put our time, where do we put our processes? And I think for me, that's where the saving of time and support. I think people, the more non-attendance letters they get, the more discouraged they get as well, don't they? So you'll probably need as a practice to have a look at the actual strategy, particularly the primary care one. I've talked about the workforce education and the sorts of things that I want to do. And for me, currently what we're doing, I think, across the county is we're relying on people's passion or kindness, but actually that creates a postcode lottery. It creates an inequality in itself, and we need to be doing that as a process. We need to, the best practice needs to be as a process. We talk about ours in our MDT meetings, our frailty and supporting families. I think it'd be really useful to find a structure for that for yourself. I won't talk too much about the secondary care one, but just to say that the interface between primary and secondary care is really important. So any referral for me, who's someone who's vulnerable, we do pick up the codes in the 2-week wait appointments, so people can recognise that there's a dementia or a learning disability. What we don't know is what happens at the other end, but if we don't give them the information, they're not going to be able to do that. So information transfer is really key. Education of your staff, your secretaries, to make sure that you remember to go and when you send someone, for example, for a learning disability, who has a learning disability, to, for example, having an endoscopy, you're probably going to need some reasonable adjustments of that. And I would be referring on to the liaison learning disability nurses at secondary care at that point to make sure that that's happening. And my ideal would be that there's a digital way of making that happen rather than us having to remember every single time, because again, that it relies on us remembering. So I've done a very, very similar thing for secondary care, and I want to just talk to you a little bit more about what we've done there. So there is a process now where for example, in Northumberland, I'm starting to develop it in Newcastle as well. If your patient cannot attend whatever, and for example needs an MRI because they've got something awful going on, or we're suspecting something awful, and they just can't manage it, there is a process now where we can get together the right professionals to work out how best to do that. So it may be that they need a sedation in the ambulance to bring them. It might be that they need some time in the waiting room with perhaps an autism sensory support bag and the right staff there to calm them down before an appointment. There's all sorts of ways of supporting with virtual reality and other distracting techniques to get people to come in and finish their, for example, MRI. So we can sedate and we can think about actually at that time, do they need a smear? Do they need bloods? Do they need the dental work looking at? Is there something that needs dealing with while they're sedated that we just haven't managed? And we would only do that, obviously, when all the reasonable adjustments have been done at home or in the surgery. For example, desensitization, where we get people to come in repeatedly, and the dental one is the key one, isn't it? The common one where they sit in the chair for 5 minutes and then they come back another time and they sit in it for longer and they have a little play, and the third time they come and actually they will let someone look in their mouth. So we can all do a little bit of desensitization, and actually the community learning disability team are really, really good at that. So I guess what I want is for people to have a look at it, and I want them to have a think about how this fits with the way they work. As a practice, obviously there's many wider applications of the reasonable adjustments, but actually just embedding this idea that adults might not be brought rather than are always DNA, and thinking that through about what that means, being proactive about mitigating that for patients. So doing it right first time with the right professional is really, really key. And we will hopefully be having some of those autism sensory bags out in primary care as well. So in summary, patients without capacity or capability cannot bring themselves. We can now differentiate that in your notes, and we can use reasonable adjustments to mitigate it. And this is across health and care. As I say, I've put the actual strategy, which is long, at the end of these slides, which obviously I'll share with Michael. I'm going to stop sharing now because it's question time. I apologise to anyone who's heard me say that a billion times, i.e. Michael. Any thoughts? Jonathan, nice to meet you, by the way. I haven't met you before.
Hello. So my first thought, I guess, something that I've taken away, and I'm sure will come in our practice. So literally just in the past week, and I don't know if it's you or something wider going on, is all of our LD patients have a pop-up coming up now saying we should make reasonable adjustments. That's fine. I suspect that's a sort of a regional wide thing. But the thing I've taken from it is
it's my.
Well, no, that's good. Well, no, that's fine. So I mean, that started to happen. But what would be much more useful is to say, this is the carer's number, this is what we need to do. Do you know what I mean? Rather, and maybe that's going to come, and I suspect maybe it will, and that was the starting point, if you know what I mean. So that was my thought, and I suspect probably it will be coming. And the second thing is when you were mentioning about the stuff with secondary care, yes, you're right. I mean, I just write in my 2-week wait. If do you know what I mean? They've got specific sections which prompt you to write these things in on the referral forms for Northumbria. I guess my other thought though was with supposedly like patient initiated review rather than routine review and stuff, that's going to be a massive, and I'm sure you've thought of that and come across it, but that was the first thought that leapt into my mind was that's going to even worse, make this even worse in terms of exacerbation of the problem, isn't it? Because
so I would assume that no vulnerable person like that would be left
should be.
But that is something that I will take away, because I don't think I'd really, I hadn't really heard that term again for a little while from pre-COVID. So I will take that back because I think that's really important. But I'm working really closely with Northumbria on this now. So I would assume that we would find a way to make that work.
That's fine. And I guess I would as well, but I guess it's worth just making sure we've thought about it, isn't it?
Yeah, no, I agree. The other thing I probably didn't mention in there, I seem to have several iterations of that talk, is I'm actually working with the ICE system. When you refer for a CT or an MRI head or something like that, I think there needs to be a mandatory field. Does this person need learning disability reasonable adjustments or any reasonable adjustments? I know for a CT it asks you, do they have communication difficulties? So I think we're probably just going to have a box or a couple of boxes like that, because again, the flag can be there, but what do we actually do with that information? And actually, I think I don't know whether the ICE people, the administrators of ICE can see that flag. So actually just belt and bracing that information, so we know that when they get that CT appointment, it actually will have been reasonably adjusted and done properly, and not scary and not traumatizing. Thank you for that. Susanna, I'm sure you've heard about this before. You'll be sick of it.
Yeah, we won the first half, so I've moved from the village around the corner from you to HMP Northumberland. So a lot of my patients don't get taken to appointments. I mean, they inevitably, all of them are vulnerable for the fact that they're in prison, but it's a slightly different vulnerability in that sometimes they just can't be taken because of security being the main priority, sadly, which is something that I'm going to have to get my head around and try and figure out the best strategy for it. But I've only been working there 2 weeks, so it's early days.
Yeah, it probably doesn't quite fit that scenario, does it? But I suppose for me, it's
No.
For me, there's a number of ramifications. If you just think about, actually, this might be not brought, it just brings a different scenario, doesn't it? It's a different sort of way of thinking about it, and
I think it really does shift that mindset.
Yeah, it does.
Even with children, you know, just changing that. DNA has been in my brain for the last 25 years, and just changing it from DNA to child not brought just changes how you think about what you should be doing.
Absolutely.
So yeah, it's really helpful.
For me, it's that hearts and minds thing about adult not brought being thought in the same way. I don't like the term flipping the narrative, but it is changing the narrative, isn't it, about what we do. Karen, it's interesting that we're all in Blythe and Cramlington and Seaton Delaval. Karen, any thoughts? So anything else that you think that that might be useful? I mean, it would be really probably good to have a look at the strategy, the primary care bit of it, particularly with your admin and managerial staff, to think about how that might be useful and how the recommendations that I've made might be used. I have spent a long time on this, so there's a lot of work in there. So hopefully I've covered most of the issues. But the landscape in which we work is changing dramatically every single week, isn't it? So we do need to think about that, for example, the PIFU stuff. Any other questions then? Just conscious of your time.
How has it gone down with sort of reception staff in terms of?
Our reception staff are very proactive about it, actually. So when the letters come in from secondary care, they're asking me, do you think this might be an adult not brought? So in the same way with the child not brought, we've got a process. So that I guess because I'm kind of leading on it, I guess they kind of probably feel a bit obliged. They're probably sick of it. But I think what they are doing is engaging in it. We're engaging in it and we are proactively dealing with it. We have a single receptionist who deals with our learning disability patients. All of our learning disability patients, if they ring on the day, they get to be seen on the day. So we have a number of sort of safety nets around that. Everyone's got a pop-up. So I think from our point of view, we probably are living and breathing this, but that's not to say we couldn't do it better. And I think for me, the better bit is the interface and what secondary care can do to sort of systematize this rather than it being relying on someone like me who's passionate / obsessed. So I think it's just making sure that every bit of the system appreciates what needs to be done. And for me, Oliver McGowan and the sort of training that we put forward for workforce will hopefully fill that gap about, actually, this doctor keeps going on about reasonable adjustments. What does she mean? What does that mean for me? And actually, there is a flag at Northumbria that tells you that your patient's got a learning disability, but that works in ED and it works in the wards, but it doesn't work in outpatients. So we're working on that, and obviously the reasonable adjustment flag will help that. But so the staff at hospital, they've got no way of knowing that patient has a learning disability until they're there, by which time it's often too late to make that appointment more acceptable and more appropriate. Thanks,
or not
Karen,
there.
for your comment. Or they haven't attended. Do you mean, but even, still with children, I had one of my patients say to me the other day, I rang to say, look, I can't make a 9 o'clock appointment because I've got 2 buses to get. And they said, well, that's the appointment or nothing. Well, I don't, we need to get our services where people find them less hard to reach. We make, and not intentionally, there's no blame here. Not intentionally do we make them hard to reach, but actually our patients find that really tough. And for our vulnerable patients, we need to be better at that, I think. Any support or help you need, just let me know. Luckily, I have a time machine, so I can fit loads more in a day than not. Thank you for listening. And please